Welcome back. We're going to be doing chapter 2, which is going to be discussing the well-being of the EMT. A lot of these topics have become a lot more relevant in recent years. We've been putting a lot more emphasis on how stress is affecting EMS, and also making sure that we wear our proper PPE and take care of ourselves from diseases we might get from other patients. COVID really did put a big emphasis on this. So on this topic, we're going to be discussing well-being of the EMT, personal protection, which is your PPE, diseases of concern that can affect us, emotion and stress that we will find on the job, and scene safety. So like I said, the well-being of the EMT is vitally important for us. We do see a lot of things that are not normal for most other professions, and if we let stress or diseases get to us, then we become unable to function as a proper EMT, and we need to know what resources we have to get help if this affects us. So maintaining your well-being comes from several different facets. We're going to need to be able to maintain solid personal relationships as with our coworkers and with our friends outside of work, which it is very, very, very important to have friends who are outside of this field, so that when you're hanging out with your friends, you aren't constantly discussing this field, because then it's like you haven't even left work. Also important is getting proper exercise and sleep. Those do kind of go hand in hand. If you are on a regular exercise regimen, then you're going to be sleeping a whole lot more regularly and more soundly. Making sure that you eat right, all three of these kind of go with each other, and limiting alcohol and caffeine intake. A huge issue with EMS is binge drinking and drinking alcohol very, very regularly, because that's a great way to mask what we deal with. And also caffeine is relatively big issue because of the strange hours that we have to work. If we're going on call at 2, 3 a.m. and you still have to be a functional person at 8 a.m., caffeine tends to help with that. But just be very mindful of how much you are consuming, because it does have negative effects, especially on your heart. And also being able to see a physician regularly to make sure that your health is in good check, and keeping up to date on vaccines, which we're going to be talking about vaccines and infectious disease a little bit later in this chapter. So standard precautions is what we use to define what we should be using on every single call, or every single call of a certain type of nature. So if we have this call with this patient, we know we should be wearing this, this, and this to protect ourselves. The goal of standard precautions is to protect ourselves from pathogens that we might take from other patients. And our scene size up and protocols are really what help guide us into what we should be wearing on every call. Now, this has been emphasized heavily with COVID patients. If you've ever gone on call with the fire department and we are told utilize universal precautions, is what Oswego County says, then we know that we're going to be wearing our gloves, N95 mask, gown, goggles, anything to protect us from getting COVID. For most standard calls, wearing gloves counts as standard universal precautions. So OSHA, which is the Occupational Safety and Health Administration, is who really sets guidelines for us to follow about how to protect against bloodborne pathogens. Most ambulances or fire departments make you take separate training to be compliant with OSHA, and usually you have to do this once a year. And it just kind of goes over how to wear your PPE, what situations to wear that. And big rule to follow is, if you're ever in doubt, go ahead and wear it. You can't be at fault for wearing too much PPE. This slide just gives some examples of PPE. Goggles are a great one that is very underutilized, especially with EMS, but that does protect your eyes, because blood can be splashed up into your face and get into your eyes. The second one is an N95 mask. Then we have two separate types of gloves. We have latex and nitrile gloves in there. Then you have a face mask with a face shield on it, which again helps protect your eyes. and then another style of N95 mask. So gloves should be worn on every single call, every single time. We should have vinyl or non-latex gloves. Almost every agency I know nowadays has nitrile gloves. They're pretty versatile. And obviously gloves should be changed between patients. You would think that that's a given, but if you're on an MCI and you're going from patient to patient to patient to patient, that's where this kind of becomes more relevant. And a way that I get to go between patients kind of quickly is you can put your new set of gloves on top of your old set of gloves. It's not the best practice in the world, but if you have to bounce between 3 or 4 patients at a time, just throw a new set on over your old set and then take all of them off at once. So this we did in class. It's a removal of gloves properly. Just make sure that you don't touch any bare skin when you're removing gloves. Start with one hand, kind of get the bottom of the glove up, peel it up, and then pull with the other side. Another huge part of PPE and keeping yourself safe is cleaning your hands after you wear gloves. The CDC has come out saying that alcohol-based cleaners are effective and they can be used in most situations. Most hospitals have hand sanitizing stations with alcohol-based ones about every 20-30 feet. It's pretty easy to just grab a quick handful as you're walking by. I usually do it when I enter the hospital and when I leave the hospital. If your hands are visibly soiled though, definitely make sure you wash your hands. Alcohol-based cleansers don't really do the best at removing visible soil. So if you have blood or any other matter on your hands that you don't want, make sure that you actually physically wash your hands. And they want you to go over how to effectively wash your hands. You should be able to sing happy birthday twice, and make sure that you have a lot of movement. You get underneath your fingernail beds, you get between your fingers, side to side, back and forth, twisting motions, because friction is what really removes the things off your hands. It's not the soap. Soap will kill germs, but friction is what actually removes it off your hands. So as we talked about, face and eye protection is something that we definitely need to consider. We are in a field where a lot of things can be spurting back at us, whether it's just a patient with arterial bleed that's going everywhere, or if we're doing a procedure on a patient, say we're suctioning an airway and they cough and it's coming right back up into our face, you're going to need to protect your eyes and face from that. Bloodborne pathogens will be able to enter your body through any sort of mucosal membrane, so eyes is a way that you can get a bloodborne pathogen to enter. So when you're doing a high-risk procedure, or if you have a patient who is spraying something out of their body, make sure that you think about your eyes and face for protection. This is an example of an approved N95 mask. These slides were unfortunately created before COVID, so the big concern that they were emphasizing was with tuberculosis patients, but as we all know, now we wear N95s around anyone that we think might have COVID. So going on further with masks, in cases where you might have splatter, wear a surgical type mask. It's standard nowadays that any ambulance crew, and really should be any EMT on a fire department crew, should be wearing a surgical mask for absolutely every single call that we go on. This protects the patient from anything that we might have and gives a little bit of barrier from what the patient might have. It is shocking how many people have COVID and don't know about it nowadays. And again, they're highlighting in cases where tuberculosis is suspected to be wearing an N95. But also, as we all know, whenever we see COVID, we need to be wearing our N95 masks. And as we discussed before, if you're suctioning out an airway, make sure that you wear a protective mask with a face shield. This is something that is very standard in the hospital whenever anything's done. In fact, if you bring a trauma patient to upstate and you have the entire trauma team waiting for you, every single member of that 8-9 person crew is going to be wearing full PPE, including a face mask with face shield, because they don't know what type of procedures they're going to be doing and they don't want to have to put that on afterwards. So we need to get a little bit better about doing that in the field, and it really is important that we protect our eyes and face. Gowns are another way to protect your clothing. If you work on an ambulance, oftentimes you're going to be wearing the same uniform for 10, 12 hours after you have a patient contact. So being able to have a gown that gives another barrier that any pathogens can stick to, then you remove that and your clothing is not soiled, is always a good idea. So we're going to discuss some diseases of concern, and we'll add COVID in there because, again, these slides were made before COVID was a thing. So hepatitis B and C, it's a disease that can cause inflammation of the liver. It is pretty resilient. It can live on surfaces and dried blood for several days. Most pathogens will die when the blood dries, but hepatitis can live for a little bit longer. Hepatitis B used to be a huge issue among healthcare workers. We were getting exposed constantly. Fortunately, a vaccine came out and most people are immunized. Most employers or fire departments will ask you upon hire if you've had your hepatitis B vaccine, and if not, they will offer for you to get it before you start work, because it is a very high risk thing that we deal with and can be very deadly to a healthcare worker if you're not vaccinated. Hepatitis C has no vaccine yet. It poses the same risk. Fortunately, it's not as prevalent as hepatitis B, but be very careful. You know, the old adage is if it's wet and it didn't come from your body, you probably shouldn't be touching it. Tuberculosis is an airborne disease. It infects your lungs and is very, very contagious. A lot of places will do what's called a PPD test, which tests you for tuberculosis and make sure that you're still negative. A lot of places will do it once a year just to make sure that you've stayed negative, and if you stay positive, then you're going to have to do a chest x-ray to make sure it's not active. Like I said, it is very contagious if it's active in your lungs, and is mainly transmitted from coughing. So if you have anyone who you suspect tuberculosis with, which we're going to talk about that when we talk about respiratory emergencies, just make sure that you wear full universal precautions, including N95, because that's the biggest way that you're going to be getting that, is through breathing any secretions that they cough out at you. HIV is fortunately starting to find some golden light. We're having a few treatments, and especially if you get exposed, you have what's called prophylaxis that you might be able to go on, which will help you not contract it if you're exposed to it from a patient. But HIV as a whole will attack your immune system, and it makes it so you cannot fight off infections. HIV can cause AIDS down the road, and that's when your immune system has just been attacked so much by HIV that it's not working anymore. HIV stands for human immunodeficiency virus, and AIDS is the autoimmune deficiency syndrome. AIDS carries a lower risk for healthcare workers than hepatitis or tuberculosis, and that's mainly because of how fragile HIV is. Really, the biggest way is contacting it with fresh, wet blood. I had a professor in college. I went to a Christian school, and when they were talking about HIV and AIDS, they're saying, you know, it's actually really, really hard to contract HIV or AIDS. You have to do something stupid like touch bodily fluids with your bodily fluids at the same time. So this is just a quick video about AIDS and the pathophysiology behind it and what a problem it was back in the 90s. This video, I believe, was made back in the 90s, but we watched it in class, so it's nothing much. So some other emerging conditions and diseases. You can tell when these slides were made. Ebola was a huge issue back in 2014, and it was, in my opinion, a whole lot more dangerous than COVID ended up being. It caused a hemorrhagic fever, and there really was no treatment for it, so the mortality rate was significantly higher than most other diseases that we see, and people were dying within 1 to 2 weeks of contracting Ebola. Fortunately, it stayed mostly in African countries and didn't make its way to the US, so the US didn't have that much of a problem with it. It is still out there, but much less prevalent. They were able to contain it pretty well. Severe acute respiratory syndrome, SARS. This is actually what COVID is. COVID is labeled as SARS-CoV-2, I believe. It's spread through respiratory droplets, as we all know. It's spread from breathing in air that someone else who is infected breathed, and you know all the different symptoms that we've been looking for, cough, fever, general not feeling well, and it can be very, very, very deadly, especially in anyone who's autoimmune compromised. Middle Eastern Respiratory Syndrome, or MERS, similar types of complaints and symptoms that we find, but it is found primarily on the Arabian Peninsula, so it hasn't really affected the US population all too much. Avian flu pops up every couple decades or so. It's found in birds, can affect humans. The reason why it's not been a huge issue is because human-to-human transmission is pretty hard to do. So it can't reach a epidemic level because it's hard to pass from human to human. A little bit easier to pass from bird to human. And then the general influenza or flu, it's been around for hundreds and hundreds of years. Some years are better than others. Some years are much worse. We all heard of the Spanish flu back when COVID became a thing. Happened around 1918 to 1920 and killed between 30 and 50 million people around the world. Fortunately, nowadays we have flu vaccines, and that can really help stop the transmission, or at least lessen the symptoms of the flu if you get the flu vaccine, which, again, we're going to be talking about vaccines, but it is definitely advisable that you get your flu vaccine and you stay up on your COVID vaccines, because we do see these patients quite a bit, and our chances of obtaining and spreading those two diseases are pretty darn high. So just for some laws, EMS personnel and other healthcare workers are at high risk, as we discussed, and that's why OSHA has developed guidelines, and they pass it down to state, federal, and local agencies to enforce these guidelines. And as we said before, your agency is going to be in charge of making sure that you're properly trained in handling bloodborne pathogens and how to use PPE. Usually that training is mandatory once a year to be compliant. Just emphasizing that OSHA standards make it fall on the employer and the employee to make sure that you're trained. So if it's been over a year and you haven't gotten your annual training, make sure you talk to your employer about it. Your employer can be fined quite a bit of money if you are not properly trained every year. And your agency should be able to provide your training, the protective equipment, and offer vaccinations for you. OSHA requires that your agency has an infection exposure control plan, that they provide adequate education and training, that they offer you a hepatitis B vaccination, as we talked about, that they provide you with personal protective equipment, methods of controlling the spread of bloodborne pathogens, and general housekeeping, labeling, and post-exposure evaluation. Speaking about post-exposure evaluation, that's where the Ryan White CARE Act came in. We've been seeing a whole lot more of the Ryan White notifications lately, but essentially what this does is it allows EMS workers to be notified when the hospital finds out that someone has an infectious disease, especially if there was any sort of exposure that happened. Ryan White makes it so that your agency has a designated officer, so if you get exposed, the hospital is going to contact that one specific person at your agency, and that one person is responsible for notifying you and arranging any sort of care that might be needed for it. They have two notification systems. The first one is the airborne disease exposure. That's where COVID falls in. There's Ryan White notifications at my full-time employer almost every single day nowadays, because a crew will bring in a patient and turns out that they have COVID, so we have to be notified through the Ryan White CARE Act. And the other one is bloodborne or other infectious disease exposure. That's if you reported that you had a needle stick from a dirty needle that you used on a patient, and then the hospital finds out that the patient has HIV. That's how you'll be notified of that. Once you're notified of an exposure, your employer will help you follow up with a healthcare profession and any further care that you might need. So going a little bit further on tuberculosis, like I said, we're going to be talking about tuberculosis as a whole and how to identify that in the respiratory segment. The OSHA does have a standard for tuberculosis separately. They emphasize using respirators or N95 masks. And when you're transporting a patient with suspected tuberculosis, make sure that you have your mask on, especially if you're in an enclosed area. And it's also not a bad idea to put a surgical mask on the patient themselves, because as we found out, surgical masks will stop the spread of a lot of diseases coming from a patient. So, talking about immunizations, those are huge for EMS. Hepatitis B is, as we talked about, the vaccination is the only reason why it stopped being a huge problem with healthcare workers, where it was a very deadly disease several years ago. Regular tuberculosis testing, as I said, about once a year. Most places will test you, make sure you haven't contracted tuberculosis. And then other immunizations, like we said, the flu shot, COVID vaccines will really help you either not contract the disease or lessen your symptoms significantly if you have a vaccination. So moving into emotion and stress, as I said at the start of this presentation, emotion and stress is probably one of the biggest issues that EMS faces and is responsible for probably the vast majority of people ending up either taking a break or completely leaving the fire department or EMS as a whole. This has come to light a whole lot more in recent years of how badly emotion and stress affects this field. So it's very important that we go over all this and how to deal with it, because emotion and stress is something that every single one of us is going to be dealing with. So physiologic aspects of stress, as I just said, stress is inevitable in the EMS profession. A lot of people try to be the tough guy and say, oh, this doesn't affect me, but it really does affect everyone to some level. So we're going to need to be able to recognize what the signs of stress are in ourselves and in people that we're close with, whether it be your partner or someone else at your fire department, and develop strategies on how to deal with stress that we face. So physiologically, there are 3 different aspects of stress. The first stage is called the alarm reaction, which is the fight or flight adrenaline response. That's if a gunman comes into your scene, that initial jolt that you get of your fight or flight is your alarm reaction. Your second stage is coping, so deciding what to do with the fight or flight reaction. And then third state is after coping is over, the exhaustion, which is loss of ability to resist or adapt to the stressor. That's really where you give in to whatever's happening. Hopefully, during the first and second stage, you're able to deal with the stressor, but if the stressor is a long-term issue, that's when the third stage really kicks in. Stress may occur as a result of a critical incident. Any real situation that we go on or any call we go on can trigger a strong emotional response, which will trigger stress for you. Acute stress reactions are often linked to major incidents that we see. It can occur in both an EMT or a patient. Say that there is a house fire where you have a badly burned victim. You can trigger an acute stress reaction both in yourself and the victim, if they're alive, will be going through acute stress. The signs and symptoms will develop very, very soon or during the incident. It will have physical, cognitive, emotional, and behavioral symptoms. And it's normal to experience the stress. Sometimes some people say that it's good to have some stress during the situation because, as we'll discuss in a little bit, there is good stress and bad stress, and good stress can help you provide care at a more effective level. Acute stress may develop into a longer term thing, and it can require professional intervention to deal with. Now, what some people say is a little bit more dangerous is what's called the delayed stress reaction. That's where you see PTSD, which we all have heard about in recent years. That's when the signs and symptoms will develop over a long period of time, and that can be dangerous because a lot of people don't know what actually is causing all these problems. You just start noticing that you're having a hard time sleeping, or you have a lot of nightmares, or you can't focus at work, or you lose interest in a lot of your activities, and this might be a week or a month or even a year after whatever happened that's causing this occurred. And a lot of times this will require intervention by a mental health professional, and that's nothing to be ashamed of at all. Most people in fire and EMS and police need to have some sort of mental health intervention at some point in their career. Cumulative stress reaction, this is what we kind of refer to as burnout. It results from years and years of sustained low-level stressors. So, going on your traumatic calls once a week for 10 years. That's where cumulative stress reaction is going to be kicking in. The early signs that you're going to see are a little bit of anxiety, emotional exhaustion, lack of interest in the job. And like I said, this is where we lose a lot of people to what we call burnout, because you just can't deal with the high stress environment for years and years and years and years without some sort of coping mechanism. It will eventually progress to physical complaints, loss of emotional control, irritability, depression. That's another reason why a lot of people in emergency services have high rates of divorce, because after years and years of dealing with all this, it begins to manifest itself in your personal life, and partners or family members will see changes in how you act and how you behave. This can also contribute to thoughts of suicide or withdrawal. All this does require long-term psychological intervention. Fire, EMS, police, once again, all have much higher rates of suicide in the profession. I personally know someone who I was working with, in 2 hours, actually not even, it was about an hour after his shift ended, he went home and shot himself. And that's unfortunately not a unusual thing to see in this field, because after years and years and years of having cumulative stress reaction, it can really get to you, and especially if you don't seek out help or don't talk to your coworkers or a professional about it, it can end up manifesting in an act of suicide or other self-harm. So what are some causes of stress that we might see in this field? One of the big ones that sticks out to everyone is what's called MCIs, or multiple casualty incidents. Those are, if you have a car accident with 15 people involved because there are multiple vehicles, or there is a bus or something like that, or your active shooter with several victims, or a house fire that had 5-10 people inside. Having to deal with several patients all at once is a very stressful environment. I speak from having to do that and having to see other people deal with that. And if it ends up being a very big MCI where you only have you and your partner and you have to treat 10 critical people, having to triage them and decide who you're going to care for and who you aren't can cause acute stress and long-term stress for thinking about that after this situation. We'll discuss how to deal with MCIs in another separate class. Other causes of stress that are common in EMS are calls involving infants or children, especially if you have a child yourself. That's very easy to see your child in that position, and that will affect you for quite some time. Any severe injury, things that you don't normally see in day-to-day activities, and it's hard to talk about with other people because they don't see it in day-to-day activities. Seeing abuse and neglect, especially in elderly or in small children, and death of a coworker. I've, like I said, had a coworker commit suicide. Very recently, I had my director of operations die relatively suddenly from an illness, and that really does take a toll on agencies and on yourself. When both those events happened, we lost a good chunk of our workforce, probably 4 to 5 paramedics left in each of those incidents, which to a small agency is a large proportion of providers. So identifying causes of stress so that you can prepare for it. Say if your dispatch is something that you think might be a high stress call, that way you can mentally prepare yourself for what you're going to see. And this is not an all-inclusive list. There are several different causes of stress out there, and your causes of stress might be different from someone else's causes of stress, and that's perfectly fine. So as I mentioned a couple minutes ago, there's 2 different types of stress, what we refer to as good stress and bad stress. Good stress is referred to as eustress, and that's the stress that kind of helps people perform better under pressure. I'm a big baseball fan. I used to play baseball in high school, and my big role was I was the closing pitcher. And people always say that that's a very stressful role because the game ends up being in your hands usually, especially if it's a tight game. But that stress helps a lot of people perform, and I loved being able to pitch in those situations. So that can be transposed to EMS. You know, if you're on a cardiac arrest, being able to get a little bit of stress reaction from that call to focus in and be able to perform quickly but efficiently is a form of eustress. On the opposite side, there's distress, which is the negative effects. It can be immediate or long-term, and it affects your health overall. Speaking of calls, there was a call I was on with AMR several years ago. It was a house fire that I was first on scene just behind one of the first arriving engines, and they pulled 5 to 6 people out of there. And the first patient that I was presented with was a 2-year-old who wasn't breathing at the time and was very, very badly burned. And as we were treating the patient, my EMT partner was ventilating with a bag valve mask and took the bag off, and half the face peeled off with that bag, which not something that humans are supposed to really see in your day-to-day life. And unfortunately, my partner, when she saw that, completely froze, and she was essentially useless for the rest of the call because her stress reaction just told her body to freeze up and shut down. I ended up having to get someone else from another crew to come in and help me because she couldn't perform after that. And that's a form of distress that we can see in our field, which is perfectly fine. And fortunately, we were in an area with lots of resources to where we could have someone replace her immediately. But recognizing what might cause bad forms of stress and being able to deal with it quickly is very, very important for us to know. Some signs and symptoms of stress that you might see. You have irritability, inability to concentrate, your changes in daily activities, anxiety, indecisiveness. Guilt is a big one that we can deal with, especially if someone dies in our care. Isolation, trying to separate yourself from friends or family, and loss of interest in work. All these are things that we see very, very commonly in our coworkers and in ourselves, and it can lead to problems both at work and at home. As I said, we have very high divorce rates because stress will get to us and we start showing all these symptoms to our family, which changes who we are. So it's just some things to think about. If you see someone either in your fire department or your partner on an ambulance showing signs of stress, how can you deal with that? That can be a one-on-one conversation with them, be like, hey, are you okay? Or going to a higher up like your chief or director of operations and saying, hey, I think this person is in some sort of trouble. We should probably do something about this, and then they can set up proper help. What possible risk could there be to your partner or you if if stress is left unresolved? Now, this can be a multitude of risks that you're running. One of which is poor patient care. If you're stressed and you freeze up, as I mentioned before, you can't adequately perform patient care. Other risks are someone can become very violent when they're dealing with stress, and they can take it out on you or a patient, or they can harm themselves. So lots of risks when you see someone who is going through a stressful situation and they aren't dealing with it properly. And that leads us to the last one, saying, do you have an obligation to act to help your partner? You absolutely do. Everyone needs to be watching out for each other. Just like if you're going through stress, you would want someone to be able to recognize that and try to seek help for you. So some ways that we can deal with stress. Lifestyle changes are a big one. As we discussed earlier in this chapter, having good dietary habits and exercise and sleep are huge. Being able to devote time to relaxing. That's something that when I first started this field, I was what you refer to as a whacker. I couldn't get enough of it. And it ended up consuming my entire life. I had no time to relax or do things that weren't fire or EMS related. And that really ended up wearing on me over time. So being able to actually have activities and hobbies that you enjoy that are not related to this field. One of my big things is in the summer I am on the lake 3-4 times a week, and I go to the golf course just as much. And that's just time that I'm not thinking about this field, and I'm actually doing something to help my body relax. And if something is bothering you for a long period of time, changing your shift or location for a different or lighter call volume, you'll see that a lot if you work at Mentor or AMR. Over a long period of time, the high call volume will get to people, and that's why they have such high turnover rates, because people just need a different atmosphere. They can't just be running constantly for such a long time. And being able to schedule more family time is huge. Again, back when I was a brand new EMT, I worked every single holiday. I was there every Thanksgiving. I was there every single Christmas. I couldn't get enough of it. And then I realized how important family time really is, especially if you have elderly family members. So being able to realize that, family does matter, and that fire, EMS, or police is not your entire life is huge to being able to have a long and healthy career. So critical incident stress management, or CISM, that's something that was developed a couple decades ago, and it's what we use to help us get through particularly bad individual calls for us. It's a comprehensive system. It includes education and resources to prevent the stress, and then how to deal with stress when it actually happens. Going back to that house fire call with my partner that froze up, immediately after that call happened, it was at like 2 a.m. or something. They called all the crews back to the station, because at AMR you don't usually go back to the station during your shift. And they initiated the critical incident stress management with all the crews that were on the call. We brought in our stress manager, who's specially trained in handling this, and your department should have someone to contact who is specially trained in this. And they just run through the call with everyone so that we can immediately discuss what we saw, what our feelings, emotions were, and then give us ideas of how to deal with the stress both that day and going forward long term. This kind of goes on further with that, with the critical incident stress debriefing, and it's, as it says here, kind of a way to help us defuse after the incident. This can be both immediately after the incident and then long term. My partner on that one day went through this initial one, and then she met for several months with our counselor to help work through the long-term effects of that call. So dealing with stress in terms of death and dying, that's something that we from the general population have a special viewpoint of, because we not only see death and dying in the field, but we see it in multiple different situations. Whether that's a very traumatic death on a car accident or any other traumatic way, or seeing someone in their own home suddenly die, and having to see family members react to that. So in the event that you do have to pronounce someone dead, or you're working on someone who just recently died, you have to understand that everyone has their own reactions to death and dying. Most people don't see death except if you're at a funeral or something like that, where it's fully expected. People aren't used to just walking in and seeing a family member on the ground who's not breathing anymore. So it is one of the most difficult parts of our job, especially if we are actively working on their family member and they're trying to process this. We have to both work on them and try to control the family member, whether that's delegating a police officer on scene to help them with it, or delegating another member of crew, or maybe the crew has enough people working on it and you get delegated to help the family member. And talking through everything that's happening, that's a big thing. And one of the huge stressors that we say is, if you are telling someone that their family member died, is using definitive words such as death, and not words like passed away or anything that might be misconstrued as something other than the person is dead. So that's something that a lot of agencies have chaplains or someone else to call in, and that's something that you can consider after the immediate reaction, is calling in a specialist to help families deal with grief. And if you have a chaplain in your department, you can talk with them more about how you might be able to act before they arrive on scene. So when you're dealing with people who are going through emotional crises such as reactions to death, dying, or serious disability, you have your 5 stages of grief. This is very important to remember. It will be tested on. So your 5 steps are denial, anger, bargaining, depression, and acceptance. Every person processes grief differently, and they go through these stages differently. Some people might skip a stage. Some people might stay in a stage for months or years, especially the depression stage. A lot of times when we're on scene and it initially happens, you're going to be seeing denial and anger mostly. People saying, no, this can't be happening, and then people being very, very upset, and sometimes the anger is directed at us. And sometimes you're going to be going through these stages of grief yourself, especially if you have to treat someone that you might know. So being aware of all these stages and knowing that people process them at a different rate is very important to keep in mind. And like I said, this might take years to actually get through acceptance. So going further on with understanding reactions to death and dying, recognize your patient first. Your first priority is the patient, and if family is getting in your way of treating the patient, say they're physically barring you from there, that's where you need to step in and have something happen. Usually a police officer can be on scene, and you can delegate them to remove the family from the situation so that you can treat the patient. But that is a big thing, is family members or friends will get in your way of actually treating the patient, or they'll be screaming at you for not moving fast enough, or they'll do something to get in your way of actually dealing with your patient. Remember to be tolerant of family members. They're going to be angry, they're going to be upset, and they're going to be yelling at you. Be tolerant and think of how you would react in that situation. Listen to them and what they have to say. Be empathetic to their needs. Definitely do not falsely reassure people. We aren't doctors. We can't diagnose. We can't give good prognoses. Big thing is, don't lie to them, because they will take any little thing that you say as the truth. And then if you say, oh yeah, they're going to be fine, and the patient ends up dying, then they're going to be very confused, and it's going to cause a lot more anger and grief to come out. And try to offer as much comfort as you realistically can to your patients and their family. So moving on into scene safety. EMS typically is not a dangerous profession, but that's because we are aware of scene safety and we can often mitigate dangers pretty well. So being aware of potential dangers is always a priority. You'll see that repeated again and again and again through class, through your skill sheets that we're going to be giving you. One of the first things that we do is make sure that you know the scene is safe. Determining scene safety is always the most important decision on any call, and that goes back to what we said in last class, is if you are hurt, you can't help someone else. So if you enter an unsafe scene and you get hurt, you can't be any good to anyone else, and then you end up becoming a patient too. So our primary rule on hazmat incidents is to maintain a safe distance from the source of the hazardous material. During your FEMA training or any fire department training, you should be able to recognize hazmat situations and be able to read placards. Most emergency vehicles do have a set of binoculars. That way we can read hazmat placards from a safe distance and not have to get up close to figure out what it is. And then you can use your emergency response guidebook to figure out what the hazardous material is and have whoever's in charge of the scene determine if it's safe for you to enter or not. So some roles that we see in hazardous material incidents is recognizing your potential problems, take actions for the personal safety and the safety of others, and notify whatever hazmat team serves your area and be able to get them on the way. Definitely don't treat a patient if they are exposed to hazardous material and still have it on them until they've gone through decontamination, because then you're going to contaminate yourself. You might contaminate all of your equipment, and again, that makes it so that instead of having one patient, you might have 3. Terrorist incidents are small or large in scale. We all remember 9/11 being one of the largest terrorist incidents to happen in this country in recent years. But there are also very small ones. a car bomb goes off, or anything that is designated to only take out a few amount of people, kind of like the Boston bombing would be considered a smaller terrorist incident. But terrorist incidents as a whole will include chemical agents, biochemical agents, radiation, and/or explosive devices. So when we're rescuing victims from fires, auto collisions, explosions, electrocutions, you have to be aware of all the different hazards that are involved in that. Most people in EMT classes are firefighters at some agency, so we all know the dangers of entering a burning building to grab someone. And definitely don't do that unless you have your proper SCBA and your proper clothing on. And then auto collisions, both knowing the hazards of what the car that you're entering has, whether that be broken glass or a fire that could start or anything else, but also recognizing the road that you're on. If it's not been shut down, it's very dangerous to enter that road to access your patient. And then explosions and electrocutions, make sure for electrocutions that the energy is turned off so that you don't accidentally get electrocuted as well. And with explosions, if it's a terrorist incident, be aware of secondary devices. A lot of times when the terrorist explosion goes off, they'll plant a second device that is aimed for the responders to the first device. So it's important to evaluate every situation and ensure that the appropriate assistance is requested early in the call, and don't do things that you don't know how to do. If you are not a trained firefighter with the proper turnout gear and SCBA on, do not enter a burning home. That will just create more patients inside. So right here is just an example of a police officer using his binoculars to see a placard at a distance so that he knows what type of hazardous material he's dealing with and can relay that to whatever hazmat team is coming in. So dealing with violence. We oftentimes will see violence from patients. A lot of times it can be if they're on some sort of mind-altering drug, or someone who doesn't want our help but is altered somehow and they can't refuse care. Or you might see violence from a family member, bystander, or someone who is out there just to cause violence to a random person who shows up. So one of the biggest things that we can do to deal with violence is pre-plan everything. Every call you should be aware that could turn violent, and you should plan for that. So one of the things that you can do is wear safety clothing. A lot of times you'll see people be wearing bullet-resistant clothing, whether it be a vest, or some places even do ballistic helmets. Preparing your equipment so it's not cumbersome is a big thing, and I always tell people to not put your equipment between you and the exit. Always put it between or somewhere where you won't have to trip on it if you have to make a quick exit. Carrying a portable radio, that way you have contact with dispatch instantaneously. A lot of people forget to bring in the radio into calls, and that's a bad move for several reasons. That, if you need different resources, say you need fire department to help you move someone, or if you need police for some reason, it's a lot harder to contact them if you have to go out all the way back out to your ambulance to grab the radio. So making sure you have a radio so that you can contact dispatch immediately is key. And decide on safety roles between the crew. A lot of times if I'm on a call with my partner, I'll have my partner do the assessment, and I'm going to stand back and kind of observe the scene as a whole. And that's my role, is so that he can focus on taking care of the patient, and I can focus on making sure that the patient and us are going to be safe during the call. And right here is another example of how to be safe on every single call. When we're knocking on a door, don't stand directly in front of the door. Stand to the side. That way, if someone is immediately wanting to attack you, it's a little bit harder for them because they're going to be looking straight on the door when they open it. And it also makes it a lot easier for them to reach out straight instead of going at an angle. So it gives you another second or two to respond to a threat that you might see. So when you arrive on the scene, survey the scene while you approach it. A lot of people will turn off their lights and sirens as they pull up onto a scene. That will make it so that someone isn't fully expecting you, unless they're actually watching outside for you. But if you make a huge scene when you show up because your siren and lights are on, they're going to know that you're there at that moment, and if they want to attack you, then they can pre-plan it a little bit. A lot of times it's a good idea to drive a few feet past the scene, especially if you are going to back into the driveway, kind of drive a little bit past the house and then back up straight and then into the driveway. That way you can see the residents from 3 different angles and make sure that you can assess any proper threats that you might see. So observation is a big way to keep you safe. Violence. Very recently, a Manlius ambulance crew showed up to a unknown medical problem call, and as they walked in, they saw a boyfriend actively stabbing the patient. They then backed off and asked for police. But if you see any violent situations happening, that's a time to see it and then back off and make sure that a police officer can come and clear the scene for you. Other things to watch out for are crime scenes, whether that be a past crime scene or active one. Any alcohol or drug use in the house. If you see drugs just laying out in the open, especially drug paraphernalia, the chances of people being violent might be higher, and you have to be watching out for, say it's heroin, watching out for any needles that might be in the area that you can get stuck with. Seeing any weapons around, it's very shocking how many people have loaded guns just hanging out in the open. So being aware of any weapons, whether it be gun or knife or anything that be used to attack you, and making sure that you keep yourself between the weapon and the patient so it's hard for them to access it. Family members getting upset with you, especially if it's a high stress situation and they think that you aren't providing care fast enough or good enough because they don't know what care actually looks like. Bystanders, same thing. They can get very upset with you. Any perpetrators, this can be a big thing for any assault calls that you go on. The perpetrator oftentimes is still on scene. And then pets. A big thing is dogs. Not every dog is friendly, and you don't know what dog is friendly and which one's not. And even ones where the owner says that they're very friendly, that's in normal situations. If the dog sees you taking their owner away, and especially if the owner is feeling sick and not being themselves, even a friendly dog can turn violent with you. So a lot of times 911 will ask people to put their dogs away before we get there. But if you see a dog on scene, try to have them be secured before we get to the patient. So reacting to a dangerous situation, we have the 3 R's. First one is retreat. That's always priority 1, is to get yourself out of the dangerous situation. Second one is to radio, so that you call for other resources, usually that being police. And third is to reevaluate. So that's, you call for police, they show up on scene, they clear it, and then you reevaluate your safety. And typically if police say it's safe to enter, then you go back in. It's just remind you to never enter a scene that's potentially violent until police have secured it and told you you're safe. If you're going into some sort of assault call, make sure that police are there first, because again, you don't want to have the assailant turn on you. When you're reacting to danger, again, priority 1 is to get yourself out of there. Get rid of any cumbersome equipment. The equipment can be replaced, you can't. So even if you have a $25,000 monitor in your hand, drop it and run, because that's going to make it much more harder to flee the scene if you're carrying a 30-pound monitor with you. And make sure you take cover and conceal yourself from any potential dangers. This is an example of concealing yourself. Make sure that not only can people not see you, but if it's realistic, to get into a place that a bullet can't travel through easily. Just making sure that you have good cover from anything. So moving on to some of our chapter review. I want you to remember that your well-being is very important to being an EMT. There have been several ways that we've discussed that you might see stress or potential dangers to yourself and how we can react to that. You should never take safety or standard precautions lightly. One slip up can be a career-ending or even life-ending mistake. So make sure on every single call you keep safety in mind, you keep your universal precautions in mind so that you don't get exposed to anything that might harm you. Protect yourself from violence and scene hazards at all costs. and protect yourself from disease. Do not be paranoid about catching a disease. That was a big thing that we saw when COVID first came out, was a lot of providers even quit because they didn't want to be exposed to COVID. But recognize that if you wear your proper PPE and you're careful, that we can effectively do our jobs and stay safe at the same time. So remembering stress can either be an immediate reaction or a long-term reaction. Both are very bad for you. Both can have effects either at work or at home, and you should be seeking professional help for both types of stress that you see. So you will see death, and you will have reactions to death, and also see other people's reactions to death. It's different for every single person, and the 5 stages of grief are denial, anger, bargaining, depression, and then acceptance. Again, that's very important to remember those 5 different stages and the order that they go through. And remember to treat people fairly and compassionately when they're going through grief. It's oftentimes really hard to do that, but understand that they're going through their own reaction, and usually we see people at their worst hour, and that's not what they normally are like, and they deserve our compassion and empathy. Scenes are often dynamic and they can change instantaneously. That's why you have to keep on reevaluating your scene, and just because it appears to be safe when you first pull up and when you first make contact doesn't mean it's going to remain that way. I remember when I was in the city, I went to a standard back pain call, and for the first 10 minutes it was fine until the guy decided that he didn't want to go to the hospital that we were recommending, and he pulled a shotgun out at us and started screaming at us to leave. So that went from a very routine back pain call to suddenly our life was in danger in an instant. Assessing the scene safety is an ongoing process, as we just discussed, and don't be so focused on the patient where you can't see what's happening around you. That goes back to what I said about typically I'll have my partners do the assessment while I'm standing back, or if it's a clear-cut ALS patient that I'm going to be taking care of, I'm going to go and do the assessment, and my partner hangs back and watches the room kind of from the entrance of the room and make sure that we're all staying safe. So some questions that we can consider. What are some precautions that you should take if you're dealing with a patient with an open wound? A lot of times open wounds can be spurting back at you, so definitely make sure you have your gloves, because that's standard on every call. Have a face mask with a face shield, and possibly even a gown to protect your clothing. And what are some ways that you can help deal with stress that you face? We discussed several different ways that you can help deal with stress. Like I said, personally, I like to go out and do relaxing activities like go boating or go out to the golf course. Every person is a little bit different on how they have to deal with stress, but this chapter gives you some guidelines on how you might be able to help with that. And a patient who refuses to believe that she has a terminal disease is in what stage of dealing with it? So if you go back to thinking of your 5 stages of grief, that one would be denial, because she's refusing to believe something's happening to her, which is your first step of dealing with grief. All right, so this one is saying that you are called to an unknown emergency at a tavern. As you approach the scene, you see a man laying supine, which means on their back, in the parking lot, apparently bleeding profusely. 2 other men are scuffling, and one seems to have a gun. What actions must you take? So this is pointing out that you pull up and you see what appears to be someone who got shot. So asking what you should do if you're still in the ambulance driving away is the first step you should take. If you go back to the 3 R's that we discussed, which are retreat, radio, and reevaluate. So if you're out of the ambulance, get back to your ambulance and drive away, or if you haven't gotten out, go ahead and drive away, which is retreating, and then radio in for help, which would be calling in for police, and reevaluating. Once police have gotten there and said the scene is safe, then your reevaluation is that police are saying it's safe, so most likely it's safe for you to enter. So those are the 3 key things that you want to do if you ever find yourself in that situation. So that brings us to the end of this chapter, Well-Being of the EMT. As we said a few times, this stuff has come to light a lot more in recent years because this is what is going to end a lot of people's careers, whether it be from getting hurt from unsafe scene or getting a disease because of lack of taking precautions when treating a patient, or dealing with stress and causing burnout. This is what will end a lot of people's careers. So it's very important to keep all this in mind, and especially the stress aspect and being able to recognize stress and deal with stress so that you can have a long and happy and healthy career.